Good morning, everyone. Today I'm sharing a part 3 video with you. This is after a lot of demand and requests from you guys that you wanted to watch a lot of more of part 3 content. So what we're going to do today is I'm going to go through how to explain placenta previa, placenta accreta, and vasa previa to your patient. Again, this is the sort of scenario which could be part of another station. So you want to be using terminology that the patient will understand and follow, and also in a time efficient manner, as you will find that in your MRCOG Part 3 exam, you just haven't got a lot of time for to be able to explain everything in a huge depth. Okay, so we'll start off with trying to explain placenta previa to the patient. So you can start off by saying the placenta develops together with the baby in the womb. It is what supplies the baby with important nutrients and oxygen whilst the baby is inside the womb. Um, in placenta previa, the placenta attaches to the lower part of the womb and completely covers the neck of the womb, which is called the cervix. Um, because of the place where it attaches, there is increased risk of bleeding both in the pregnancy and also at the time of birth. This is normally diagnosed at the 20-week scan, but is reconfirmed at 32 weeks and at 36 weeks because some placentas, which may look like they have attached quite low in the womb, as the pregnancy advances and the womb grows, it will move out of position. So, in terms of how it will affect the pregnancy and the baby, there is increased risk of bleeding both during the pregnancy and at birth. With placenta previa, the recommendation of birth will be by cesarean section, and this will be a planned cesarean section in order to be able to prepare for the higher risk of bleeding that is associated with a placenta previa. Now, there's also something called low-lying placenta, which is when the placenta is less than 20 millimeters from the neck of the womb, but is not covering it. Now, for placenta accreta, you want to say that the placenta accreta is quite rare. The incidence is between 1 in 300 to 1 in 2,000 pregnancies. Now, this is where the placenta starts growing into the muscle of the womb, and there's a risk that it may also reach other organs that surround the womb, like the bladder, for example. This can be quite serious and there's higher risk of bleeding, both again during and at birth. It will normally be diagnosed with a ultrasound scan to start off with, but will need further imaging like an MRI scan to be able to see the extent of the growth of this sort of placenta. Now, with this sort of placenta, apart from bleeding, there's also higher risk of potentially requiring a hysterectomy, which is completely removing the womb at the time of delivery because of increased risk of bleeding. Now, what is vasa previa? Now, vasa previa is even a more rare condition compared to the previa and the accreta. The incidence is between 1 in 1,200 and 1 in 5,000 pregnancies. Now, this is where blood vessels that are traveling from the baby to the placenta are unprotected by any placental tissue or the cord. And can pass very close to the neck of the womb. These vessels can be quite delicate, and when the waters break, either naturally or are attempted to be broken artificially, these vessels can be damaged, and if these vessels are damaged, the bleeding that will happen is blood from that is being supplied to the baby. So baby um, can lose a lot of blood in a very small amount of time. And babies haven't got a lot of reserves to start off with anyway. This can make the baby very unwell, and normally signs of this can be seen with on the baby's monitoring, with baby's heartbeat going off, and also having quite a lot of bleeding soon after the waters are broken or artificially uh, or if they were artificially broken as well. Um, this will require an emergency urgent cesarean section to try and save baby's life. So things can happen quite quickly, and to be able to avoid any harm to baby. Now, if this was picked up during the pregnancy, then usually a planned cesarean section is recommended around 34 to 36 weeks to try and deliver baby before labor is started or before the waters break. Now, I hope that was useful as a beginning for you in terms of getting things started off, because you don't want to be using lots of medical terminology. You want to be using very lay term, layman's language to be able to explain to your patient what's going on and also the urgency of it without getting them too scared. Because if your patient suddenly feels too terrified in the exam, that also reflects quite negatively. So you want to be doing all this in a reassuring manner. So you want to be giving this information, checking understanding, get the patient to repeat the information you've told them. If the patient seems too focused about when the delivery will be, you want to be answering that question first and not having them to wait before you finish your spiel before and then go on to the delivery. So if the patient comes in saying, I just want to know when my baby will be delivered, you have to answer that question, because it's you cannot get the patient to wait 10 minutes before you get onto this. So you want to be giving this information in small chunks, checking understanding every time you give this information, and you may be able to draw in the exam, especially if the exam is face to face. You will have a pen and paper and you can draw things, so it helps with you with you being able to show what normally where the placenta would grow, and then what happens in placenta previa and accreta and so forth. So use your diagrams and drawings if you are able to do so, because that really helps make a simple message come across really clear, and the patient can also keep that diagram for them just to go in at home and show it to their partner or their family if they wish to do so.